Hello, good evening. Thank you, Sue, for inviting myself, Joe, and Wahida and Karen to present this evening at this very special Netflix event. We are really thrilled to be here and feel very honoured to share this space with you all. So without a doubt, the field of genomics holds immense promise and potential for improving the outcomes in maternal, fetal and newborn health. And throughout our presentation, we'll explore how genomics intersects with maternity and newborn care. But first, let's take a short moment to look at the overview of what we're going to discuss tonight. As you can see, our talk, as Sue mentioned, is presented in two parts, with part one focusing on biology basics and the scope of genomic activity along the maternity and newborn pathway. Then part two here will shine a light on some examples of genomics in clinical practice, which Karen will cover, as well as information about education and training, the resources available, and networking opportunities. So, to kickstart this talk, it's important to make you aware about the NHS England National Genomics Strategy, which was published in 2022. The strategy is a national key driver which has set the ambition of embedding genomics within NHS clinical services. There are clear references to maternity and neonatal genomics, some of which are already embedded, which Joe will cover soon, but there will be also on the horizon more to come. So I highly recommend you dip into this document, which can be found very simply online. If you just type in National Genomics Strategy in Google, it should come top of the list. Thanks, Joe. So let's move over to some fundamentals about genetics and genomics. Every cell in our body contains a genome, the complete set of our DNA. Imagine it as a recipe book with all the instructions for our bodies to grow, develop, and function. This book is organised into 23 chapters, or chromosomes. These chapters contain 20,000 sentences, which are the genes that we all have, which are long strings of DNA in varying lengths. And these sentences comprise of 3.2 billion letters known as bases or nucleotides, and the letters A, T, G, C. They come in pairs, A with T and G with C. And you may be familiar with that little illustration in the bottom left-hand corner, the double helix, which Watson and Crick are renowned for. So where is all of this leading? Next. Well, genomics covers a broad range of very clever tests that harness molecular technology, which can explore the genome at various levels and for a range of different indications. Here you will see some of the laboratory techniques that are offered in pregnancy to test for chromosomal and genetic conditions. On the left-hand side, in blue, is the karyotype. This is used to look at the largest component in our genome, which is the chromosome. As a technique, the karyotype has been around for many years and it was developed in the 50s. Over on the other side, in yellow, are genomic tests, highlighted in gold and yellow. Now, clinical scientists use the karyotype to check the number, size, and shape of chromosomes in a cell. They also check for missing additional duplicates or rearrangements. Its most common use is to check for trisomy in pregnancy, trisomy 21, 18, and 13. So what they're looking for is this extra chromosome on a pair of chromosomes. Now, since the emergence of genomics, new tests are available, and as mentioned, these are highlighted in yellow and gold. So to the right, you'll see QF-PCR. This is a quicker test using non-cultured cells and specifically looks for the number of copies of certain chromosomal regions. On the bottom left, you can see microarray, again, a quicker method to detect chromosomal abnormalities. This high throughput and high resolution technique uses microchips containing thousands of DNA sequences. It checks for tiny pieces of missing chromosomes or duplications. Bottom right is something fairly new called exome sequencing and is currently used in fetal medicine and the neonatal setting, where technology can examine the region of the gene that codes for protein. And that region accounts for around about 2% of the whole genome. The residual bit is called the intron or introme. Now, each gene contains instructions for building a particular protein, which takes on a unique shape to make it functional. And this technology can check for gene alterations known as variants, which change the order or sequence of our DNA. Essentially, it interrupts the function of protein coding. Next. At one time, we used to refer to variants as mutations, but this term is no longer acceptable due to its negative connotations. And in practice, particularly in genetic practice, parents, patients, and families really didn't like this. So now you'll hear interchangeable terms such as gene variant, gene alteration, gene change, which are far more acceptable and comfortable. Just to add that we all have genetic variants, where nobody's perfect. That's what makes us all different and unique. And overall, for most people, having these changes are harmless. However, for some, it can be the cause of a rare genetic condition. Next. Now, using the analogy explained earlier, here is a simple example to explain this. So if you look at the bottom, we have a sentence. Once there were 4 children with a tick. That makes sense. It's spelled correctly. It's a complete sentence. The second line, once there were 4 children, there are spelling mistakes highlighted in yellow. Phonetically, it sounds okay and it makes sense despite the spelling mistakes in those 3 words. And the third example, won't were 4 children. That clearly doesn't make sense because there's been deletions and there's also been a shift of the letters. So the reason why I'm using this example is to basically simplify what variants actually do. So although there's a spelling mistake, as I mentioned, we all have spelling mistakes in our DNA, but that doesn't necessarily cause ill health or rare disease. But for some people, it could cause a problem. But clearly, the deletion could be more of a problem. And now I'm going to go over to Wahida, who's going to talk about the role of epigenetics. Thank you.
So most health professionals, including midwives, they understand the terms genomics and genetics, but many need to understand the term epigenetics. As health professionals, we discuss epigenetics every day, such as when you're taking the booking assessment, looking at modifying lifestyles to improve health outcomes. But we necessarily might not think that's epigenetics. So epigenetics is a study of how your behaviors and environments can cause changes that affect the way your genes work. Unlike the genetic changes, epigenetic changes are reversible, and they don't change your DNA sequence, but can change how your body reads a DNA sequence. So the genetic changes can alter which protein is made, but epigenetic changes affect gene expression, so turning genes on and off. The environment and behaviors such as diet and exercise can result in epigenetic changes. Next slide, please. So I'm going to just focus on 4 areas of reproductive health maternal care. Firstly, preconception and preimplantation. So poor nutrition can lead to adverse epigenetic changes that can have an impact on fertility. The environmental exposures, such as toxin pollutants and endocrine distributors, can cause epigenetic changes that can affect reproductive health. As chronic stress can lead to epigenetic changes, impacting hormone balance and reproduction functions. Thus, this can lead to epigenetic changes that affect the endometrium's ability to support implantation. The choices we make in our daily lives, such as smoking, alcohol consumption, and physical activity levels, can influence epigenetic markers and significantly affect reproductive health and pregnancy outcome. And research has shown that epigenetic alterations in sperm and oocytes, as well as in the endometrial lining, can contribute to infertility and implantation failures. During pregnancy, essential nutrients like folate and B12 vitamins are crucial for DNA methylation and, of course, fetal development. With malnutrition leads to epigenetic changes that can affect fetal growth. Exposure to pollutants, toxin, and endocrine disruptors can cause adverse epigenetic modifications, which can result in congenital abnormalities and long-term health issues. Chronic stress and hormonal imbalance can induce epigenetic changes. This impacts the fetal brain and organ development and potentially leads to behavioral and cognitive disorders. Additionally, it's important to be aware that smoking, alcohol, and drug can result in harmful epigenetic changes affecting fetal health, such as IUGR, placenta dysfunction, etc. In the postnatal health period, breastfeeding provides nutrients and bioactive compounds that support healthy epigenetic development. This influences immunity and the metabolism. So early nutrition is essential for healthy epigenetics programming, affecting growth and cognitive development and the metabolic health. Clean air, safe housing, and a supportive environment can mitigate negative prenatal epigenetic influences. So in contrast, positive parental interactions and a nurturing environment promote healthy epigenetic modifications, supporting emotional and psychological well-being. So in conclusion, epigenetics has profound implications for preconception, implantation, pregnancy, and postnatal care. Understanding how epigenetic mechanisms affect fetal development and long-term health can help midwives provide comprehensive care, supporting mothers and their babies. I will now pass on to Jo.
Thanks, Wahida. So, I guess now you're thinking that is all great, but why do I care? Why do I need to know? And it's because each and every one of you have a role to ensuring that women get the appropriate care, not only for them, but their families and also those future pregnancies. The standards of proficiency represent the skills and knowledge that all midwives must demonstrate. And within these, there's no surprise, sits genetics, genomics, and epigenetics. So as Wahida has very clearly identified, epigenetics has a role in influencing the health in pregnancy. But I really want to now take you through the pregnancy and newborn journey, where you might expect to see an element of genomics in your day-to-day practice within the UK. So we'll start with early pregnancy. During that booking assessment, midwives are key to identifying red flags in a family, medical, or obstetric history. So ensuring that you get as much information as you can ensures that timely referral to fetal medicine or clinical genetic colleagues for that informed discussion about testing options. And some examples of those red flags might be that there is more than one or two family members within with the same condition or similar symptoms, or there's recurrent miscarriages. We move on to screening. So women are offered antenatal screening and scanning opportunities for chromosomal and structural conditions at around 12 and 20 weeks. And in fact, there's now been a development of non-invasive prenatal testing, or NIPT, which is a genomic test that has been available since June 2021 within the screening pathway for specific chromosomal conditions. And that's reduced the number of women needing to access diagnostic testing such as amniocentesis. And this year, NIPT has been expanded, but my colleague Karen will cover that in session 2. At around 16 weeks, for women who are rhesus negative, there is the offer of cell-free DNA testing to identify the rhesus D gene in the fetus. And that in itself has reduced the number of women receiving unnecessary anti-D. In fetal medicine, non-invasive prenatal diagnosis is an evolving technology that can detect a limited number of conditions that are caused by an alteration in a single gene. Rapid prenatal exome sequencing is also a fairly new technology, which increases that diagnostic yield of a genetic condition for those where a structural problem has been identified on a scan, but where other prenatal tests did not provide an answer. Let's now move into the antenatal side of things. The antenatal assessment or walk-in attendance, they present opportunities to spot undiagnosed inherited conditions such as cardiomyopathies by being vigilant about new or acute symptoms. By questioning women about their family history of similar symptoms or conditions could lead to a quicker diagnosis and appropriate management. Now, midwives on labour ward may encounter women with genetic conditions or be involved in the care with a family where a genetic condition has been identified with the baby. We all know labour ward and birth are a highly anxious time. And if midwives have the key knowledge of a condition, the pregnancy journey, and what management plan is in place for either that mother or baby, it can lead to reassurance and an improved experience. For the bereaved family, genomic testing within the post-mortem could provide a cause of death for the unexplained stillbirth, providing families with much needed answers and planning for future pregnancies. In the postnatal setting, midwives play a crucial role. Not only midwives actually here, it's GPs, it's health visitors, all of you play a crucial role in detecting issues in babies. Listening to parental concerns and recognizing signs of rare conditions is essential. And there are occasions where genomic tests may be recommended for a neonate. Rapid trio whole genome sequencing is offered to the acutely unwell child, likely to have a condition caused by a one gene change. And these tests can support the immediate clinical management. And then when we think about genomics, we can also think of it when considering treatment options. So an example is that some people have a gene change which can predispose them to hearing loss when given a certain antibiotic, such as gentamicin. And there is genetic testing available for those with a predisposition to gram-negative infections, for example, those known to have respiratory disorders such as cystic fibrosis. Now, when we take that into a situation such as sepsis in the newborn, we're not quite there yet. So there are current efforts to use rapid point of care testing strategies so that it can be implemented into routine care. So those babies who do need urgent treatment can still have that genetic test and avoid harm. Finally, research midwives are likely to come across genomics within their portfolio. And one research project that is coming soon is the Generation Study, which you will hear about more in session 2. So that concludes session 1.
Thank you, Jo. So welcome everybody to session 2. And in part 1, what we did was describe, sort of set the scene really. We described how genetics, genomics and epigenetics feature in everyday maternity care. In part 2, what we want to do is take a deeper dive into a couple of examples. Firstly, where genomics is already making a difference with the R445 pathway. And secondly, look into the future with a research program called the Generation Study. Now, these 2 examples that we've chosen are from NHS Care in England. And I'm aware that some of you may be dialing in from outside of England. So I'm hoping today will inspire you to go and find out what testing pathways and what research is going on in your locality. So, next slide, Jo. Starting with R445. So this was implemented across England in April of this year. R445 is the code in the National Genomic Test Directory, which offers NIPT or non-invasive prenatal testing to women who've previously had a pregnancy with a full trisomy of 13, 18 or 21. The rationale for offering NIPT to this group of women is that we know they've got an increased chance of having a trisomy in a future pregnancy. So what we're doing is providing them with an opportunity to proceed to a more sensitive screening test and at an earlier stage of pregnancy than is currently offered on the fetal anomaly screening program in England. So essentially what we're doing is making NIPT more widely available. Next slide, please. So let's just remind ourselves of the principles of NIPT screening. So when a cell breaks down, it releases some DNA into our circulation. So in pregnancy, the mother has some of her own cell-free DNA circulating in her bloodstream. But also we have the placenta with its rapid cell turnover. And that also releases cell-free DNA into the maternal circulation. So we know that this cell-free DNA from the placenta is pregnancy specific because it's cleared very quickly after birth. And of course, it's very important that we know that that cell-free DNA relates to that particular pregnancy when we're going to use it for genomic testing. We can take a small sample of maternal blood and sequence these small fragments of cell-free DNA and quantify them. And where we find extra chromosomal material for a specific chromosome, then that might indicate that there's trisomy in the baby. Now, in most cases, placental DNA matches the DNA of the baby, but that's not always the case. And therefore, this is a screening test. It's not diagnostic. We do have a different test available called NIPD, or non-invasive prenatal diagnosis, and that is available in England on the NHS for a small but increasing number of monogenic conditions. And if you want to know what conditions we can offer NIPD for, then I advise that you go and have a look at the National Genomic Test Directory and see what tests we can currently offer. But anyway, let's go back to NIPT and the R445 pathway. So when we're offering R445, you should consider it to be a pathway rather than a standalone test. And of course, we start off at booking by ascertaining whether a woman has had a previous history of trisomy. And if she has, at that point, we would refer to an appropriately trained midwife or a genetic counsellor. And at that appointment, there'll be a pre-test discussion at which we would confirm whether they're eligible for the R445 pathway. Now, if you want to know about the eligibility criteria, again, I suggest that you look at the National Genomic Test Directory, which is available online. And if a woman is eligible, then they get offered 3 options. The first option, of course, is not to have any screening tests at all. It's always the woman's choice. The second option would be to have NIPT on the R445 pathway. And thirdly, they can choose to go direct to prenatal diagnosis if they want to take the risk of miscarriage. But some women will want to find out for sure at this point. We can offer NIPT for this for screening from 10 weeks right up to 21 weeks and 6 days. And we offer it. The offer of R445 replaces the offer of the combined all quad test on the FAST pathway. Remember, we're offering them a more sensitive test and at an earlier stage in pregnancy than they would get on the FAST pathway. Now, it is screening. It's not going to detect all pregnancies with trisomy. It might not detect a partial trisomy or a translocation or a mosaicism. Might not detect other rare chromosome disorders. And obviously, this will form part of the pre-test discussion. Next slide, please. So we have developed a suite of resources to support the implementation of the pathway. We have a R445 working group, and these resources include a pathway document, a flowchart taking you through the pathway. We have information leaflets for parents, for healthcare professionals. Obviously, we've got the National Genomic Test Directory with the entry for R445 in it. We've also developed an entry for GeneNotes, and if you're not sure what GeneNotes is, Donna is going to tell you more about GeneNotes in a minute. We also have a training module that's under development. Now, the pathway document and the information leaflets were sent to all trusts in advance of implementation of the R445 pathway, and we are going to host these online, so they'll be available to everyone. We're just waiting for senior sign-off at NHS England at the moment, but hopefully they will be available shortly, and we will write to all trusts when that is the case. So far, we've had a lot of positive feedback from women who have been able to access the R445 pathway. Understandably, they may have more anxiety in a future pregnancy, having had a trisomy previously. And many of them were talking about the fact they were going to self-fund NIPT. So the fact it's available on the NHS is obviously a benefit for these women. So next, I'm going to talk about a new research study called the Generation Study. So R445 is already out there, it's making a difference, but with the Generation Study, it's a new research project exploring the potential for genomics in expanding newborn screening. The QR code on the slide, which should come up, I don't know, Joe, if you just want to see if it will come up there, but the QR code, oh, no, it will take, there you go. So it will take you direct to the participant website where you can see some of the patient information leaflets about the Generation Study. So let's just talk about it in a little bit more detail. Next slide, please, Joe. So it is a research study. It's being led by Genomics England in partnership with NHS England. Our aim is to undertake whole genome sequencing on 100,000 newborns across England to screen for over 200 different conditions. Specifically, we're looking for rare, treatable genetic disease that has a early childhood onset. So we are only looking for disease where we have a treatment which will improve outcomes. We are not looking for carriers, we are not looking for adult onset conditions, and we are not reporting variants of unknown significance. The aim is to recruit parents during pregnancy, and then after birth, we'll take a sample of cord blood. If we can't get a sample of cord blood for whatever reason, then we can take a heel prick test, or if the baby's in NICU, we can take a sample from a line. And the aim would be to get the results returned within 2 weeks. That's the long-term aim. We know it's going to take much longer than that in the first few months of the study. Overall, we expect to have 1,000 condition suspected results returned during the study. And there's been a lot of work going on in the background to establish the confirmatory testing pathways for these children and ensure that we have clinicians ready to receive them into their care as the study progresses. So there are 3 main goals in the study. The first is to establish the utility and feasibility of using whole genome sequencing as a screening test. Now, we've not used whole genome sequencing in this way before. Normally, what happens is we have a baby or a child with a condition that we haven't been able to diagnose. And at that point, we might look at whole genome sequencing to see if there's an answer within the DNA. With this study, we're using it as a screening test. So we're starting off by looking at the DNA to see if we can find a condition before the baby becomes symptomatic. So we're kind of turning it round, if you like. Secondly, we hope to learn more about genes and health. So we'll be asking about how we can use genomic data for future research to develop and improve both testing and treatment on the NHS in the future. And thirdly, we'll be exploring long-term implications of storing that baby's genome over the course of its lifetime. And the plan is to approach these children when they reach age 16 to ask for their consent to remain in the programme. And at that point, we can consider whether we revisit their genome, and we have the potential at that point to look at perhaps adult onset conditions. So next. The question you should be asking if you're a midwife, you should be familiar, of course, with the newborn blood spot screening program. And you should be asking whether this newborn blood spot screening is the same as the Generation Study or if it's different. So on the next slide, what I have given is an overview of the two, just as a comparison. Of course, they're both screening tests, they're not diagnostic. In both cases, we need to perform diagnostic testing to confirm whether the baby has that condition or not. The Generation Study is going to look for many, many more conditions than newborn blood spot screening. And of course, it's a genomic test. We're looking at the DNA. In newborn blood spot screening, what we're doing are looking for biochemical markers in the blood. And those are present because the baby has a condition. which may or may not be genomic in origin. Now, one of the things that concern us is that maybe midwives and parents might look at this and say, well, generation studies got to be better. We're looking at genomics. We're looking at many more conditions. This is state of the art. We have to be really clear that newborn blood spot screening is a well-established screening program. It's evidence-based. It's got proven clinical benefit. It's offered to all children. It saves lives and it improves outcomes for many children. As of yet, we certainly won't be offering this at every site in England, and we don't yet have the evidence. We don't know whether whole genome sequencing will work as a screening test or not. And if you take the example of something like congenital hypothyroidism, which we screen for on blood spot screening at the moment, not all cases of congenital hypothyroidism are genomic in origin. And therefore, the generation study, if a baby had the generation study without having newborn blood spot screening, we might miss some of those cases, and that could be disastrous. So to be very clear, if you only take one thing away from my section of the talk, it is that the generation study is not replacing newborn blood spot screening, and all parents participating in the study must still be offered and indeed recommended to have newborn blood spot screening for their baby. So where are we in implementing the study? Well, so far we've gone live in 3 sites in England. We're starting very slowly, and then over the course of the next year, we'll be building up to implement the study at 40 different trusts across England. When we consider what sites to launch the study at, we don't want just to focus on teaching hospitals. We want to look at different types of maternity services. We want to ensure that there's diversity in the data that we produce. Certainly, we want to ensure that the data that we generate from this study is representative of the population of England, and therefore that we include people from different ethnic backgrounds. And we also know that maternity care is very challenging at the moment for some units, so we want to make sure that the maternity units that host the study are able to do so at this time. So even if you're not working at a site in the future that's hosting the generation study, we think that all midwives need to be aware of it, because there's likely to be questions from parents going forward. So I'm now going to hand over to my colleague Donna Kerwin, who's going to talk about where you can find out more about genomics and genetics. Thank you.
Thanks very much, Karen. So to support midwives and nurses in their learning, there are a range of free blended educational resources available on the National Genomics Education Programme website. These resources cater to different learning styles and levels, including a dedicated genomics and midwifery landing page. Overall, there is plenty for everyone to look at and select. Next slide, please, Jo. So this is a list, which is not exhaustive, which lists the most popular resources that midwives and nurses tend to go to, from novice to specialists, being from Genomics 101 for the novice, working right through to various other things, webinars and podcasts, and of course our midwifery landing page. And in this list, you'll see a reference to the Genomics Week of Action, which Sue alluded to earlier, which is currently online this week. So the aim of the Genomics Week of Action is to extend broad reach to all healthcare professionals and generate discussion about genomics. So if you've not been on Twitter, please go and have a look. You can still join the party and join your genomics journey. And of course, anything that you do can count towards revalidation. Just to add that each Genomic Medicine Service Alliance offers education and training, and these come in the form of events across the localities. All are advertised on their websites and of course on Twitter and LinkedIn. And once again, there's a plentiful resource to choose from. Just recently, I contacted all local midwife educators via the RCM to explore the status of genomics within their degree programmes. I did receive some positive feedback, albeit smaller than expected, and discovered that it's beginning to infiltrate. It's encouraging to know that several universities have successfully included genomics in their curriculum, and some are actually beginning the process. So if you're a lead midwife educator online tonight, I'd love to hear how you're getting on. We're more than happy to try and support you. The RCN also is come on board with upskilling midwives in genomics. And I've been working closely with the RCN for the past year to develop its iLearn module, Genetics and Genomics in Midwifery. It's become a great resource now, which has had a real revamp, and already feedback is coming back to the education and research team. So do have a look at that as well. Next slide, please. Now, Karen mentioned GeneNotes. This is a real key resource which has been developed by many clinician and midwife, genetic counsellor, supporting the genomics education programme. And GeneNotes stands for Genomic Notes for Clinicians. It's a free, concise, on-learn clinical and educational portal to be used in the clinic at the point of need and for extended learning. GeneNotes covers 9 specialities, one of which is fetal and women's health, and each domain comprises of 2 sections. Tier 1 in the clinic. This is the landing page for Tier 1. This is an example which is built around clinical scenarios. So in this example, you can see that it's dedicated to cystic fibrosis. And when you click in further into this example, you'll see that it'll provide you with information about pathways, referral processes, and which are the suitable tests available for cystic fibrosis, which are cited in the National Genomic Test Directory. The Tier 2 part of GeneNotes is called the Knowledge Hub, and essentially a Wikipedia where you can obtain more information about rare conditions, and it also hyperlinks to other key resources. As co-chair of the Fetal and Women's Health GeneNotes Working Group, I'm really proud of what we've developed, and particularly as we are the only group that includes clinicians, midwives, and genetic counsellors in developing the content for this speciality. Next slide, please. So as well as online resources, the National Genomics Education Programme also funds individuals for under and postgraduate study in universities, ranging from standalone modules to masters in genomic medicine. One course which midwives have found really helpful is the University of the West of England Genomics and Counselling Skills for Healthcare Professionals course. This is a nationally recognised course and is ideal for midwives wanting to upskill in genomics and develop resources to plug into practice. As you can see, our colleague Wahida is on the screen, who is the lead GMSA midwife for North West region, and another one of our colleagues, Denise Barnes, for North Eastern Yorkshire. And both have been through this course. UWE, University of West of England, have just closed the recruitment for 2024 to 25, but next spring plans to advertise for another 50 students. And in this year's cohort, they've accepted 10 midwives on the course, which is absolutely amazing. If you are interested in this course, please scan the QR code at the bottom or get in contact with me, and I will signpost you to Professor Aniko Varadi, who is the module leader. Next slide, please. And again. And finally, before we close, I'd like to introduce you to our national group, the Midwives in Genetics and Genomics Network, affectionately known as MIGS. We're a friendly group of about 50 midwives and specialists, non-midwives from across the country, working together in harmony to integrate genomics into routine clinical practice. Our aim is to raise awareness by bringing along all levels of midwives and non-midwives from across the country to learn, share, and informally network. Our do once and share motto approach allows us to scale local ideas to become national products, where we can streamline approvals and avoid unnecessary duplication of efforts. And we are looking for more midwives and specialists to get involved. So, for example, if you are a midwife sonographer, a bereavement midwife, a community-based midwife, or even a maternity support worker, please do get in touch, and we would, like to see you join our party. Just to say that this is the national picture, and midwives that are highlighted in green. Some you can recognise from this screen, but others that represent our counterparts in North Thames and South East London and South West. But we also engage wider with Genomics England, the RCM, the RCOG, and the Association of Genetic Nurses and Counsellors. So please do feel like you've got a place in our group. Next slide, please. So before we wrap up, I'd like to thank you again, Sue, for inviting us to present this evening. We hope that you now have a better understanding of genomics in terms of what it means in clinical midwifery practice. This is just the beginning of a longer journey, and we've just tipped the iceberg, but we hope that you found our presentation informative and valuable. Thank you for your time and attention.